You in 3, 2, 1.
Hi, good evening, everyone. Welcome to another Wednesday, another set of webinar. Today, we're going to talk about heart failure. And I have here my friend, DATO Dr. AZMEE, who I need to call DATO Dr. AZMEE. Okay, there has been a lot of new progress in heart failure, both in pharmaceutical treatment and also in devices in the treatment of heart failure, which of course Dr. AZMEE will discuss further. And without further ado, come, Dato.
Hi, Dr. Betty. How are you?
Okay, the only reason why I have to call him Dato Dr. AZMEE is because he keep on insisting on calling me Dr. Betty.
Of course, I think that's an honor, isn't it, Dr. Betty, to call you Dr. Betty?
Please. Okay, go on,
Okay.
Dato.
Okay, can I share my screen?
Yeah, please.
Okay, all right. So, good evening, everyone, and thank you very much for listening today. And what we're going to discuss in the next 45 minutes or so is to look at some of the advances that we have in managing patients with heart failure. So, of course, I think the topic that Dr. Betty gave me is new and the old. So we look at some of the changes and what is the current recommendations, when you treat patients with heart failure. So before that, I'd just like to start with a case. It's always good to start with a case. So this is a 43-year-old gentleman. He is 169 centimeter, 66.8 kg, B positive from Perak. And he has a history of dyslipidemia. He's an ex-smoker. And he has a history of an anterior MI about 5 years ago. And he had a PCI to his LAD. But subsequently to his acute myocardial infarction, he has heart failure with reduced ejection fraction. So his ejection fraction is only 18%. And because of this, he has multiple admissions with acute decompensated heart failure, and he remains to be in function class 3 to 4. And of course, looking at his current medication, he's already on good guided directed medical therapy. So I think the 4 pillars of treatment for HFrEF include sacubitril valsartan, a beta blocker, and also an SGLT2 inhibitor, and also an MRA. So these are the 4 pillars of treatment that we need to ensure all patients with HFrEF without contraindications to be on. And of course, at the same time, he's requiring quite a high dose of diuretics. Bumetanide, he's taking about 1 milligram 3 times a day, which is quite high. And of course, he's on lipid-lowering therapy and also antiplatelets as well. So when you look at the blood investigations here, you can see here that the NT-proBNP is very high. And NT-proBNP or BNP is a biomarker to look at prognostic. We can diagnose patients, and you can also use it for prognostication of patients with heart failure. These patients clearly, has a very elevated NT-proBNP. So in an outpatient setting, patients with heart failure, we want the NT-proBNP to be as low as less than 1,000. And I think those are, has been studied that if you keep them as low as 1,000 in patients with heart failure with reduced ejection fraction, then their outcome is much better. Of course, the chest X-ray consistent with heart failure, and he has a narrow complex QRS on his ECG. So this is his echocardiogram. I'm sure you can see here. So he has an ejection fraction about 20%, but he has an associated moderate to severe functional MR. And this is quite common, in patients, with patients with heart failure with reduced ejection fraction with functional MR, where you see, the LV dilates, and of course the functional MR is there. And this actually complicates matters because a lot of patients are very symptomatic with it. Of course, the other thing is, what we want to see is what are the problems, what are the potential that we can help with these patients with advanced heart failure therapy. Number one is we can consider a device therapy with an ICD. This patient have a narrow QRS complex, so not suitable for CRT. Because these patients has a functional MR, then we can consider H2H mitral valve repair with the use of mitral clip. And of course, at the same time, we can consider either heart transplant or mechanical circulatory support. So this is essentially, what we're going to discuss in the next 45 minutes or so, looking at some of these parameters of treatment that is available for patients. Okay, as I mentioned, there have been a lot of advances in patients with heart failure. As you can see here, in a nutshell, despite guided directed medical therapy, we have to think, more forward. How do we treat patients? How do we improve their quality of life? And also, I will tell you what are the recommendations, some of this treatment, later on in this lecture. So if you can see here in this patient, this patient has a mitral clip for his functional MR. This patient had a trach valve, to actually, because the patient has an associated severe tricuspid regurgitation. He also has a pacemaker, and this chest X-ray, this patient had an ICD implanted and also a left ventricular assist device, LVAD, that has been implanted. So these are some of the technologies that we have in terms of treating patients with heart failure. Okay, before that, I'd just like to mention why is heart failure important? The reason why it's important is because there are more than 60 million people worldwide living with heart failure. It is also one of the leading cause of hospitalization. And in patients above 65 years old, it is the #1 cause of hospitalization. These patients who are admitted with acute decompensated heart failure has a high risk of readmission again. So they will keep coming back to the hospital with the same problem of heart failure hospitalization. And it is estimated up to about 30% will be readmitted within 90 days, within 3 months after their first hospitalization. And of course, we do know that in terms of mortality, the outcome is very poor in patients with heart failure, whether it's heart failure will reduce or heart failure will preserve ejection fraction. Up to about 30% of patients who are hospitalized will die within 1 year. So what is the prevalence of heart failure? I think in Europe, it is estimated about 2% of patients with heart failure in Europe. But in Malaysia, we're looking at about 1 to 2% of Malaysian population suffering from heart failure. So in a population of about 36 million in Malaysia now, so we estimated about 300 to 600,000 people living with heart failure in Malaysia. And of course, the prevalence is much higher in elderly age group, up to about 10% in patients above 65 years old. Okay, so now how do we diagnose? What is the mechanism of making the diagnosis of heart failure? So #1, of course, we need to know that patients who are presented with signs and symptoms of heart failure, shortness of breath, paroxysmal nocturnal dyspnea, orthopnea, bilateral ankle edema. So those are some of the signs and symptoms, in patients with heart failure. And I'm sure you are very familiar with it. But when you want to make a right diagnosis of heart failure, you need to collaborate the signs and symptoms with at least one of the following. #1 is either you have an elevated natriuretic peptides biomarker, and this can be either an NT-proBNP or a BNP. So we use more often NT-proBNP in our clinical setting. And of course, the cutoff is if you are seeing patients in the outpatient clinic, stable heart failure patients, then the NT-proBNP of more than 125 give you a diagnosis of heart failure. But patients who do you see, in the emergency department, then the cutoff is more than 300 to make the diagnosis of heart failure. Of course, if you don't have a way of measuring an NT-proBNP or BNP, then you can also do the conventional investigations, for example, a chest X-ray and also an echocardiogram. And of course, in some patients, in the certain diagnosis which is still unclear, especially in heart failure with preserved ejection fraction, you may want to consider a right heart catheterization in this group of patients as well. Okay, so, and this has been echoed in many guidelines. So as you can see here in the ESC guidelines 2021 and also in the American guideline in 2022, making the diagnosis of heart failure still based on signs and symptoms of heart failure using these natriuretic peptides, using an echocardiogram. And based on the echocardiogram, you need to try and define what is the heart failure phenotypes, whether it's heart failure with reduced ejection fraction, which is LVEF of less than 40%, whether it's preserved ejection fraction with LVEF of more than 50%, or it's mildly reduced ejection fraction, which is between 41 and 49%. And the reason why this is important is because the treatment modalities and recommendation is still based on heart failure phenotypes. So we still need to know what the ejection fraction when we want to try initiate treatment, guided directed medical therapy, because the recommendation is still based on LV ejection fraction. And of course, at the same time, it is not just making the diagnosis of heart failure. You need to find what is the actual cause, of heart failure. So you need to know the etiology. So whether this is ischemic in origin, whether it's genetically, or whether it's dilated cardiomyopathy, whether it is related to arrhythmias, for example, tachycardia-induced arrhythmia, or patients with thyroid disease or problems with anemia that can actually lead to patients with heart failure. As I mentioned, heart failure has high mortality, and you can see here mortality can go either during the acute phase, during immediately post-discharge, and in the chronic phase as well. So the mortality is along this path, whether, as I said, whether they've been admitted or whether they're quite stable as an outpatient as well. So I would like to introduce this. This is a MyHF registry. So I'm one of the investigator. And this is the first prospective multi-center registry of heart failure patients in Malaysia. So this was started back in 2019, and Prof. Wan Azman is the lead clinician, in this registry. And of course, if you can see here, 18 participating hospitals, and these hospitals are big center hospitals throughout Malaysia in each state. And we managed to include more than 2,000 or 2,673 in precise patients who are hospitalized for heart failure. And these patients were analyzed looking at their demographics. So what we found is we found that majority of the patients who were admitted with acute decompensated heart failure are male, up to 66%. And we do found that majority of the patients who are admitted with acute decompensated heart failure in Malaysia still belongs to heart failure with reduced ejection fraction. That's up to about 67%. However, if you can see here, heart failure with preserved ejection fraction, EF of more than 50% is up to about 22%, and mildly reduced ejection fraction is up to about 11%. So you can see still here, even there is a substantial number of patients admitted with PEF and also mildly reduced ejection fraction. In terms of age, we are much younger compared to our European and American counterparts. Our mean age of patients presenting with acute decompensated heart failure is 60 years old. This is about 10 years younger than our American and also our European counterparts. Of course, in PEF, we do know that majority of the patients are older, so the mean age of patients presenting with heart failure with preserved ejection fraction is 65 years old. And we also look at comorbidities. We know that there are multiple comorbidities. And again, we see it in patients, despite whether they have heart failure with reduced, mildly reduced, or preserved ejection fraction. The most common comorbidities in patients with heart failure is hypertension, which is followed by diabetes, ischemic heart disease, dyslipidemia, CKD, obesity, atrial fibrillation, and also sleep apnea is very important as one of the comorbidities. So it is important, in patients, with heart failure, either preserve or reduce ejection fraction, you need to ensure that this patient doesn't have sleep apnea, because if you treat the sleep apnea, then you can actually relieve the symptoms or treat the heart failure on its own. Okay. In terms of the outcome, because we're interested to know in Malaysia, what is the current outcome of patients, that is actually surviving with heart failure. So looking at our in-hospital mortality, so when they're admitted to the hospital, our in-hospital mortality is up to about 2.9%. And our 30 days mortality after an acute decompensated heart failure is 5.8%. And our 30-day readmission is up to about 11.4%. So we know that we do have a high burden, and this outcome is similar across ejection fraction. In IJN, I think this is a bit more localized data. We found, we actually have done a 10-year history of patients who are hospitalized with acute decompensated heart failure. And last year, we published this in our ESC heart failure. So what we found that our rehospitalization rate is up to about 6.8% in 30 days. 1 year is up to about 24%. And our 1 year mortality is up to about 7.2%. And we found that prognostic marker for mortality at 1 year, we found that patients who have a lower weight, lower BMI, lower blood pressure, higher heart rate, higher urea, serum potassium, creatinine, and uric acid, lower sodium, and a lower eGFR has a higher rate of mortality. So these are some of the markers of mortality that we can see, in patients admitted with acute decompensated heart failure. So I think I've given you enough burden, I've given you enough data to suggest that it is a very, very, disease burden in Malaysia. And of course, what is the current treatment recommendations? So, and when we are facing with patients with heart failure, the reason why we treat them is because we want them to feel better. We want to reduce symptoms, improve their quality of life, and also functional capacity. We also want to prevent heart failure hospitalization, and we also want to improve patient survival by reducing mortality. So in heart failure with reduced ejection fraction, it is clear that you require a 4 pillars of treatment, standard of care in all patients without contraindication. So the recommendation is to combine ARNI or RAS inhibitor plus a beta blocker plus an MRA and also an SGLT2 inhibitor. So this is without a doubt that these are actually recommended in all patients with heart failure with reduced ejection fraction. And of course, if you have symptoms, if the patient is breathless, then you need to consider diuretics, for example, furosemide to relieve this congestion. And of course, all this recommendation has been backed up with proper studies. And these studies has been done either as early as 1999 with the use of beta blockers comparing bisoprolol versus placebo. And there is also most recent one, which is an SGLT2 inhibitor, which is DAPO-HF, which was published in 2019, actually shows in terms of reduction in terms of the composite endpoint versus placebo. And of course, some of you, and I'm sure some of you have heard of Paradigm-HF, looking at comparing ARNI, versus enalapril, that actually shows a superiority in terms of reduction in terms of mortality and heart failure hospitalization. And of course, in terms of MRA, looking at eplerenone versus placebo, actually shows superior in terms of reduction in mortality and heart failure hospitalization. So all these 4 pillars of treatment has been backed up with proper clinical trials, randomized clinical trials. So in terms of our Malaysian guidelines, the latest one was 2019, and this is actually due to be updated and to be presented and published for all of you. But what we currently have is looking at the ESC, the European guidelines, and also the American guidelines. Again, as I mentioned, when we look at all the specific guidelines, the ESC has also emphasized the use of 4 pillars of treatment in heart failure with reduced ejection fraction. And again, at the same time, in terms of the American Guidelines 2022, also has actually recommended the 4 pillars of treatment in all patients without contraindications for heart failure with reduced ejection fraction. So, of course, there are some meta-analysis, Dr. Betty, that has been done, looking at is it really true, that these 4 pillars of treatment benefits patients compared to 3 treatments or 2 treatments? So this meta-analysis is very interesting. They actually look at the combination of ARNI, beta blockers, MRA, and SGLT2 inhibitor, and also the other combinations as well. So you can see here, in terms of the reduction of cardiovascular death and heart failure hospitalization, it is the highest, up to 64%, if you do this combination for treatment, of combination, which is ARNI, beta blockers, MRA, and SGLT2 inhibitor. But when you look at other combinations, ARNI, beta blockers, and MRA, you can see only a reduction of 53%. And of course, if you combine if you give beta blockers only, then you can see only a reduction of about 25%. So I think, it is clear the recommendations is there, all these 4 pillars, and there is also other meta-analysis that actually confirms, this benefit that you can see in patients with heart failure with reduced ejection fraction. So the question now is, how do we give this? How do we give all these 4 pillars of treatment, isn't it? So now we've given 4 to choose. How do we choose? And of course, the previous recommendation is for us to do a conventional sequencing. So we start with ACE inhibitor OARB, we maximize the dose, then we add on beta blockers, then you add an MRA, and then you maybe switch the ACE inhibitor to ARNI, and then you add an SGLT2 inhibitor. But this is actually an old story. The reason is because to actually get into optimization of a target dose, it probably requires up to 6 months. So the current recommendation, which was, there's few recommendations with regard to how do you sequence this. And one of it, which is very interesting, which was published and actually proposed by McMurray, and this actually looked at the rapid sequencing algorithm. So you can combine a beta blocker plus an SGLT2 inhibitor, then you can add ARNI plus an MRA. And all this step must be achieved within 4 weeks. And then once you have we started all these 4 pillars, then it is good for you to up-titrate to a target dose thereafter. So in a way, I think you don't have to, start one, wait, see how the patients respond. But ideally, is actually to start them all together as soon as possible within 4 weeks, and then you up-titrate the dose according, to their response, in terms of blood pressure and the heart rate. So I think enough about heart failure with reduced ejection fraction. I think we are quite clear. The 4 pillars of treatment, it is clear for all patients with heart failure with reduced ejection fraction. So now what we do is we go into the treatment recommendation for mildly reduced and preserve ejection fraction. So in 2022, the American guidelines actually put in an SGLT2 inhibitor as a class 2A recommendation in either mildly reduce or preserve ejection fraction. Because at this time, there is not much or many clinical trials supporting SGLT2 inhibitor in the treatment of this group. But of course, recently, 2023 in the ESC, this actually had an update in terms of the diagnosis and the treatment of patients with acute and chronic heart failure, and what they have recommended in patients with mildly reduced, so this is between 41 to 49% ejection fraction, that SGLT2 inhibitor has been given a class 1A recommendation in treatment of patients with mildly reduced ejection fraction. So you can see here, even ACE inhibitor, ARNI, ARB, MRE, and beta blockers is only a given class 2B recommendation. So SGLT2 inhibitor is really the only one that has been given a class 1 recommendation. How about PAF? I think PAF is also very interesting. You know, as you can see here, in terms of the recommendation, only an SGLT2 inhibitor, either DAPA or empagliflozin, has been given a class 1 recommendation, a level of evidence A, and this is the highest recommendation that you can give in any treatment, and it is the only recommendation of the treatment in heart failure with preserved ejection fraction. So I think, ladies and gentlemen, I think now that we do know that there is a treatment for mildly reduced ejection fraction and preserved ejection fraction, so I think it is important for you to make the right diagnosis, and of course, to try and treat your patients accordingly. But
At
the
this
only thing,
point of time, sorry.
of course.
Yeah, I'd like to say that this is not a sponsored talk, yeah?
It is not, definitely
Yeah.
not, but then of course, but the reason why I'm telling it is
That's right,
because,
that's right.
yeah, that's right, so it's
It's-
never, so I think, the other thing is, Dr. Betty, is when you look at a PAF, you also need to look at what are the comorbidities in this group of patients, because PAF is a little bit different. So when you diagnose this with heart failure with preserved ejection fraction, and usually it's elderly female, majority of them have coronary artery disease, some of them have obesity, some of them have iron deficiency, anemia, and I think that's quite important, for us to look at some of the other phenotypes, that you need to elucidate and should treat them, in patients with heart failure with preserved ejection fraction. Okay, I think I've talked enough about the treatment modalities of heart failure with reduced, preserved, and also mildly reduced ejection fraction. I just like to go into the other aspect of treatment of heart failure.
Can you explain to us this class 1A
Yes.
for preserved and mildly reduced? Yes. What evidence are there?
Of course, I think, in
do you have any others further slides?
I don't have, because I
Okay.
think, some, because I don't want you to say that it's actually a sponsored, sponsored.
Yeah, that's right, that's right.
Yeah, of course.
Yes.
Of course,
But tell us more about this, because I'm very interested.
Yeah, of course, in terms of, the SGLT2 inhibitor, Emperor preserved, has actually, shown a significant mortality benefit, and also reduction in heart failure hospitalization in the use of SGLT2 inhibitor, which is empagliflozin, and these are, one of the most important, recommendations that actually put them as a class 1 recommendation, Dr. Betty.
Yeah, and okay, can you drop the Dr. Betty? Okay. But can I ask, in these studies, were they compared with placebo?
Placebo,
You can, right? Because ethically it's fine, because everything else does not prove to be significant.
Yes, that's right. Yeah, because even, when we look at ARNI, the treatment of ARNI, it does not show any significant benefit. The only time that they actually did is when they actually combine the data, in terms of reduce and preserve ejection fraction, then they can see a little bit more, improvement in terms of the use of ARNI. But of course, SGLT2 inhibitor actually gives you a little bit of a different, different aspect, because it is clearly that it is significant benefit for this group of patients.
This SGLT2 inhibitor is amazing. It's almost like, the ACE inhibitor coming in many years ago, when we first started even evidence-based medicine in the use of in heart failure and in coronary artery disease. And until now, we don't know how it works, right?
Definitely, I think the only thing is there's a lot of treatment modalities that we don't know how it works, so in a way,
Explain with, let's say, ACE inhibitor or ARNI, or even beta blocker, but I can't see an explanation for this,
No,
especially when it is with even preserved heart failure.
that's
And
right.
I
Yeah.
love the drug so much because you don't have to worry so much about the blood pressure being low.
Yes, that's right.
Yes, and then it's so well tolerated by most people.
Yes,
And
that's right.
there's no need for, not much need for titration because it's
That's
just
right.
one dose.
Yeah, the dose that is recommended is 10 milligrams,
Yeah.
either EMPA or DAPA. You rightly say, and I think that in terms of tolerability as well, it's actually quite good. You know, patients do tolerate this quite well. The only thing that you have to be very careful is if it's an elderly female, male, above 80 years old, you have to be a bit careful because some people actually lose significant amount of weight with this. And of course there is a risk of infection, either genital infection or UTI. Very, very uncommon, but higher risk in elderly populations. And the other thing is that you have to remember that if the patient is going for major surgery, I would discontinue it for a few days. And I think that's quite important for us to remember.
And the other thing that is that, sometimes patients with preserved heart failure are not so easy to treat compared to not as easy as we think, right?
Yes, that's right. Yeah.
Yeah, and now we have an option for them.
Yeah, and I think, in all patients with PEF, I think SGLT2 inhibitor will be the first treatment. But of course, at the same time, look at their risk factors, because the multiple risk factors in terms of obesity, hypertension, atrial fibrillations that you need to treat. Yeah, so don't just treat the PEF, treat about the other comorbidities as well.
Okay.
Okay, so I think, we're quite clear now, I think, in terms of the treatment for REF, PEF, and also mildly reduced ejection fraction. But what I would like to show everyone here is not just about guided directed medical therapy, it's about everything else in terms of treating patients. Of course, when we look at the ESC guideline 2021, in terms of reducing heart failure hospitalization and improving quality of life for all patients, then we require a multi-professional disease management, what we call a multidisciplinary team. And I think this is quite important. So wherever you are, which hospital you are, please consider a multidisciplinary team approach in managing patients with heart failure. This is an example in IGN, this is what we have. So when patients comes into the hospital, there'll be nurse in our heart failure ward, they will be entered into our clinical pathway, which is standardization of patients treating with heart failure. And all these patients' data will be collected into our registry. After their discharge, we can have a phone call, some have home visit, they will go for cardiac rehabilitation. And of course, in terms of the follow-up, we have either teleconsultation clinic, we have our multidisciplinary clinic, and also we give them educations. And of course, in IGN as well, we have advanced heart failure care and also palliative care. So when you're planning, heart failure services in your center, think about multidisciplinary care because it is a class 1 recommendation in the ESC guidelines. I think this is quite clear. Yeah? So, of course, the other thing is, of course, I would like to mention is about this management of patients when they are admitted during acute decompensated heart failure. Because we know that during that acute decompensated heart failure, it is the best time for us to initiate treatment, up-titrate the treatment, and that is also the best time for us to ensure that they have a proper follow-up. So the most recent ESC update, it has given a class 1 recommendation that intensive strategy of initiation and rapid up-titration of evidence-based treatment before discharge. Please remember, before discharge and during frequent and careful follow-up visit in the first 6 weeks following a heart failure hospitalization. So it is clear that it is recommended that you need to initiate the medication, guided directed medical therapy before discharge, and you need to plan the patient and you need to see the patient within 6 weeks after they have been discharged. It is a class 1 recommendation, Dr. Betty. And of course, I just like to mention that in IGN, we started back in 2000.
Dr. Betty, please.
Okay, yeah. So we started this back in 2019. And so what we did was we knew that, these patients require optimization treatment possible. So what we did is we started this multidisciplinary team clinic where it covers the pharmacists, our heart failure coordinators, and also doctors. And most of these patients will be seen within 6 weeks. We optimize their GDMT, we monitor, and we give them education. And I do have some data that I would like to share here in terms of our clinic. So when we look at here, of course, as I mentioned, pro-BNP or anti-pro-BNP is an important surrogate marker for prognosis of patients in terms of response of treatment. So you can see here, the BNP, pro-BNP at first visit compared to the follow-up, there is also a significant reduction, when you can see them, as early as possible for optimization. And this is actually looking at the treatment itself. So when you can see here, in terms of the one in gray, is the patient comes in, the medication that has been discharged when they come in the first visit. And of course, majority of the treatment above, achieve more than 75%, okay, more than 70%. And of course, after they've been seen in the clinic, in the subsequent follow-up, which is in black, you can see here more and more patients actually receive guided-directed medical therapy. So this is what we want. We want most of your patients who are discharged from the hospital will be on guided directed medical therapy, up-titrate the dose, send them home early, and then ensure that the dose is up-titrated, or in some patient who has not been started on GDMT, you should initiate it during this early follow-up. And I think this is also quite important. And this is class 1 recommendation.
Can you go back to the previous slide, please?
Of course.
Okay, so this pro-BNP,
Yeah.
the follow-up, do you routinely check for pro-BNP in all patients with heart failure or recently admitted with heart failure?
Okay, usually in our practice is we use BNP biomarker during admissions to confirm the diagnosis and to prognostic the patient initially. I would do prior to discharge to look at the response, and of course one during outpatient follow-up. If cost is not an issue, I would do in subsequent follow-up as well.
I see.
Yeah.
Because okay, I used to think that clinically, if the patient is
Of course, yeah,
heart failure, there was no need for pro-BNP. But I found it to be useful now to actually, see whether the patient is tolerating the medication, not only tolerating, but improving with the treatment.
Yeah.
And I just had a patient yesterday who had a pro-BNP of 22,000.
Yep. Okay.
It can be so high, huh?
Yeah, we can. The only thing is, if they have renal dysfunction, maybe you can increase it. But of course, 22,000, you do know that whatever treatment that you're giving, you need to optimize. And maybe if the patient can, may require advanced treatment, maybe it's something that you can consider.
Okay.
Yeah. So as you can see here, we do measure it, during our first visit and also our subsequent visit as well. And of course, the challenge with this is the cost issue. It is not cheap, this biomarker that we have. But I would advocate to try and use it as much as possible, looking at, to try to prognostication in this patient. Okay, so iron deficiency, I think this is also quite important. Okay, it's not really new in the topic, but of course it has been emphasized now and again. So in patients with heart failure with reduced ejection fraction and patients with mildly reduced ejection fraction, it is now a class 1A recommendation that you need to treat these patients with intravenous iron supplementation. Okay, so, and I think, this is also very, very important that we need to remember to try and check their iron level, and of course, in terms of the definition is that if you have iron deficiency with a serum ferritin of less than 100, but if you have a serum ferritin between 100 to 299, then measure the transferrin saturation, and the transferrin is less than 20%. And this is a definition of iron deficiency in heart failure. It is not a definition of iron deficiency in anemia. It is a definition specific for heart failure. And of course, the current recommendation is to treat them with IV iron. So this is, most recent, guidelines, 2023. And of course, I think, we echoed that as well. I think, we did it before, so what we did is actually in our center currently, we advocate most of our cardiologists to check their iron for patients with heart failure, their iron. And if they're low during clinic, we will give them intravenously during the outpatient clinic. So they will get it checked, they will get the infusion, and they will go home on the same day. And of course, for our center, we use either Monofer or we can use ferric carboxymaltose. So these are the two choices that we can give, because these injections can be given quite fast during an outpatient setting. Yeah, I don't know whether do you do this, Betty, in your clinical setting?
No, I don't. I don't have that. Okay, I have to admit, I don't have the knowledge initially.
Okay, right, yeah. But I just hope that I think everybody is now familiar with this, and I think it's very, very important.
Yes.
And it's actually very easy to treat. Of course, it doesn't improve, it doesn't reduce mortality, but it alleviates symptoms and improve quality of life. And we do know that patients with heart failure, they can't breathe, they can't walk, they can't sleep, and they have limited in terms of their exercise capacity, and anything that we can improve their symptoms will be beneficial for the patient.
So we don't actually look at the hemoglobin per se.
Not at all.
Yeah.
Yeah.
It is very interesting.
Yeah. So I think this
Because
is...
we don't even do iron serum ferritin or on a routine basis for all my heart failure patients.
Yeah,
Now
I think, yeah, of course, the best scenario is during an acute decompensated, you can check and then you can treat, and it's easier to give intravenous during hospitalization. But now, currently, it is also recommended as an outpatient as well.
Okay.
Yeah, I think this is something very interesting. And of course, as I
Yes.
mentioned, we knew about this, so we anticipate this, and we started the clinic much earlier, and it is running quite well. And I think most of our cardiologists now started to check their serum ferritin and so the transferrin saturations routinely in patients with heart failure. How routine? Maybe every 6 months or a year. That's something that you should consider.
Okay.
Yeah. Okay. So the other thing is, okay, I think, you cannot go away with regards to, advanced heart failure therapy, when I give a talk, I'm very sorry. So what I just want to emphasize that in patients who doesn't respond with the treatment that you have given, you always have to consider advanced heart failure therapy. And this has been given a class 1 recommendation and also class 2A recommendation, class 1 in heart transplantation, and class 2A recommendation in patients with left ventricular assist device, LVAD, as either a destination therapy or a bridge to transplant. Okay, so this is something that I will focus on in the next few slides. So first of all, I would like to mention, how do we define advanced heart failure? How when you see patients, what is your definition? Number one is patients with persistent symptoms of heart failure, class 3 or 4. Okay, that's number one. So they have to have severe symptoms. Number two is you have an objective evidence of severe cardiac dysfunction. So number one is either the LV ejection fraction of less than 30%, or if they have an isolated RV failure, for example, patients with ARVC, they have a normal LV functions, but only isolated right ventricular failure. They have severe valve abnormalities, which is inoperable, severe MR, severe TR, severe ER, for example. Patients who are born with congenital abnormalities, or patients who have persistently high BNP or anti-PUBNP, in that sense, that can be criteria as one, of a severe cardiac dysfunction. Number three is patients had few episodes of unplanned hospital visits in the last 12 months, more than one unplanned visit. So this is also quite important. And of course, number four is severe impairment of exercise capacity. So you kind of need all these criteria, for us to try and diagnose and make a diagnosis of advanced heart failure. And of course, in terms of severe impairment of exercise capacity, inability to exercise, unable to walk, if you can perform a 6-minute walk test is quite important. And of course, if you can do a VO2 max is quite important. But I think is this okay, in terms of definition, advanced heart failure? And I think it's quite clear, isn't it?
Yeah.
Yeah, I think, this is something very interesting that everybody needs to know, because a lot of people say, how bad do you have to wait? What is advanced heart failure? And this is clearly, and this is actually based on the ESC 2021 criteria. And of course, as I mentioned, in terms of cardiac transplantation, it has been given a class 1 recommendation in patients, who doesn't respond to medical or device therapy without any absolute contraindication. And in terms of our criteria, so in IGN, we perform cardiac transplantation. We do have a strict criteria in terms of looking at patients' suitability for cardiac transplantation. Majority of it, is, we can accept, but of course there is a cutoff age between 18 and 55 years old. The reason why we do that is because we want to have a good outcome in patients going for cardiac transplantation. But in fact, you can even transplant a patient which is above 70 years old, but of course their chances of survival is much less. There is also several contraindications that we need to remember. So patients who require cardiac transplantation ideally will require, or all of them will require, a right heart catheterization, because we need to see whether there's any evidence of significant pulmonary vascular disease. So we wanted to know what is the pulmonary pressure is. We wanted to know what is the PVR. We also wanted to know what is the transpulmonary gradient, because if the pulmonary pressure is high, the PVR is high, and also the TPG is high, based on this criteria, then they are not suitable for cardiac transplantation. Because when you transplant a normal heart into somebody criteria like this, then the right ventricle of a normal heart will struggle. They will not be able to cope with a high pulmonary pressure like this, and you have a significant RV failure immediately post-transplantation. So the selection criteria is very, very tedious. Of course, we also want to make sure that the patient doesn't have end-stage renal failure, for example, or end-stage liver failure that might poor prognosis for this patient. So these are some of the criteria that we have for cardiac transplantation. Yeah. Betty, can I proceed?
Yeah, go on.
Yep. Okay. Right. Okay. So the next one, of course, IGN. I think we've done this many years. So this is Uncle Albert is the longest surviving cardiac transplantation back in 1998. So up to 25 years, and he's still surviving. Of course, there's some degree of renal dysfunction, this and that, but he's still very happy at home, very stable. He has not been admitted, and he's doing very, very well.
How old is he now?
He is now 72 years old.
Oh, that's great.
Yeah. So, okay. So in terms of LVAD, okay. So the other thing is the issue with cardiac transplantation is because majority of the patients sometimes cannot wait for heart, because it's very difficult, in terms of our donation is quite low. And of course, to get a good heart, a healthy heart is also quite difficult. So what we can do is now is actually, rather than going for heart transplant, then we can consider mechanical circulatory support, which is a left ventricular assist device. And the current recommendation is a level 2A in whether you implant this and then you wait for a heart, what we call a bridge to transplant, or as the destination therapy, which means that you implant the LVAD until the end of life. And it's been given a class 2A recommendation for these two treatment. Okay, yes.
How long will it last?
Okay, the longest, of course, 10, 15 years, but then, of course, the modern LVADs will last longer. The issue with LVAD is usually the complications that happens with it, which is sometimes is infection, because the wire comes out in the abdomen, so it comes out. So where the exit side of the wire usually have problems with infection, there is also a risk of stroke because of the clot that can happen, in the pump itself.
What kind of do you use antiplatelet or do you use NOAC?
Yeah.
Or
all the patients will have to be on warfarin, and all the patients have to be on a single antiplatelet. So they take one single antiplatelet, usually aspirin, plus warfarin.
Oh, so it's warfarin. You don't use any of the newer generation of
Not at all.
Okay.
Yeah. Okay. So, when we want to evaluate patients for an LVAD, so this is an example of an LVAD. So what happened is this LVAD, this pump is inserted in the left ventricle. So it only supports the left ventricle. So if you have biventricular failure, the patients cannot go for a left ventricular assist device. They require a BiVAD, which is more complicated, which we don't hardly do. The reason why is because to manage patients with BiVAD, is very, very complicated. So what we do is actually in patients with the LVAD, this LVAD will suck the blood out from the left ventricle, return back into the aorta. So it's actually just bypassing the blood through the aortic valve. So it's actually quite interesting concept. And of course, it can be used either as a destination therapy, which means that you implant the LVAD until the patient succumbed, later on, or you can implant the LVAD until there is a suitable donor of the heart, and then you remove the LVAD, remove the heart, and then go for a cardiac transplantation. So it has been approved for these two indications.
This implantation is through surgery, and
surgery.
Is it keyhole surgery? No.
No, it is an open heart surgery similar to an open heart CABG.
Okay.
Yeah, so it's done by our cardiothoracic surgeon. And of course, as I mentioned, the issue with an LVAD is always problems with stroke, pump thrombosis. Of course, these are some of the challenges. But of course, the third generation LVAD, deemed to be last longer and with lower risk in terms of the thrombosis. Okay. So the first implant was 2005, and the last implant we did it this year as well. And I think patients are doing very, very well. They can go home, they can go back to work. With this, the only thing, there's a battery outside that they need to charge the battery. Apart from that, they can't swim, but apart from that, they can do most activities that they want to at home, really. Okay, I think, before I finish, I just want to just mention a little bit about functional MR. So in patients, that I presented just now with severe heart failure, you can see when the LV dilates, there will be a significant functional mitral regurgitation. And of course, in this group of patients, usually they actually have a very poor survival. They have to be admitted to the hospital very frequent. And of course, in patients like this, when you refer them for surgery, they are very high risk, surgical high risk, so they will not go for a mitral valve replacement or repair because of the heart failure itself. So currently, when we look at the recommendation in terms of the American guidelines in 2022, so it is recommended that patients with function class 2 to 4 with severe secondary MR, suitable anatomy, with an ejection fraction between 20 to 50%, with an LV and systolic diameter of less than 70 millimeter, not too large, with a PA pressure of less than 70 millimeter mercury, then this patient can be considered class 2A recommendation for them to go for a transcatheter edge-to-edge mitral valve repair. So the current, what we have is actually mitral clip, that we perform. And this mitral clip is done percutaneously, okay? And of course, it actually goes through into our vein, okay, femoral vein, and then goes into the IVC into the right atrium. And of course, you have to do a transeptal puncture into the left system, and then you go into the mitral valve and you clip it. Okay, so the idea of this procedure is not to completely relieve the mitral regurgitation, but is to reduce the severity of the mitral regurgitation. So anything, that we can reduce in terms of the functional mitral regurgitation will benefit the patient in terms of the symptoms and reduction in heart failure hospitalization. Okay, so this is something that, I would like to mention, because a lot of people see heart failure patients with severe functional MR, then they just treat medically, they don't do anything. But of course, there are avenues of treatment without surgery, currently it's available, and it's been approved and it's been given a class 2A recommendation. So, and of course, when we look at patients with MR, of course, they have to have significant MR, severely symptomatic, despite guided directed medical therapy, despite all your GDMTs that you started, and also at the same time, they are not suitable for surgery because of either they have heart failure, severe heart failure, or they are elderly, for example. Then these are the patients that you need to consider whether they can be suitable for edge-to-edge repair with a mitral clip. But of course, there are a few investigations, for example, TEE, transesophageal echocardiogram, that we need to do to actually look at the morphology and also the anatomy of the mitral valve for us to ensure whether it's suitable or not. And then, you can actually perform mitral clip after that. Yeah. So, I think, Betty, I think, I've spoken enough. I think really, so what I, done in the last 45 minutes is actually saying that there is a clear recommendation with regards to guided directed medical therapy. And I think all of us are familiar with that, with the use of, ARNI ACE inhibitor, plus a beta blocker, plus an MRA, plus an SGLT2 inhibitor in patients with REF. It is clear now in terms of recommendation for mildly reduce and preserve ejection fraction, class 1 recommendation with the use of SGLT2 inhibitor. I think that's quite clear. Of course, I mentioned about IV iron in patients with heart failure with reduced and mildly reduced, and also mentioned about advanced heart failure therapy, multidisciplinary team care, and also, the latest one is the treatment of patients with functional MR. Yeah, with that, thank you.
Amazing. It was such a good talk. I'm so happy.
Thank you very much. Yeah.
Okay. We do have some questions.
Of course, yeah. I think that'd be great.
Yeah, and do try this the form and see, please, so that because initially we couldn't get into the CPD point form. Now I've reopened it up. Let me just go through the questions. But I see that in your guidelines, you don't have ivabradine anymore.
Okay. So ivabradine is more of a rate control. It is still in the guideline. You can still use ivabradine, but it is not class 1 recommendation. So ivabradine is used that if you cannot reduce the heart rate to less than 70 beats per minute in sinus rhythm, despite a high dose, tolerable high dose of beta blocker, then you can use ivabradine. It is still in the guidelines.
I see.
Yeah.
Okay, I'm sorry, I can't seem to see where's the chat. Okay, I see it now. So let's see. Dr. Sasi from Doquity asked, is beta blocker SGLT2 combination or beta blocker ACE inhibitor ARB preferred? I think you have mentioned this, that there was a slide that is really very good where Dr. AZMEE showed where a combination of all these 4 pillars actually can reduce the heart failure mortality and endpoint by 65%.
Yes, 64%.
64%. Almost there. Anyway, so you have to use, it's best that you use all 4. So question 2 is Dr. Mohana asked, how soon can we initiate beta blocker in acute heart failure? Okay. That tells you the age of the doctor asking, I think. Because I was brought up when heart failure was is contraindicated, beta blocker was contraindicated.
Okay, yeah. So this is very interesting because I think the question is very interesting because there is a guideline, from Australia actually mentioned, in terms of the recommendation of initiating treatment. So usually for beta blockers, once they have decongest, then you can start them quite safely. So, for example, if there's no crackles, there's no much of an edema, then you can start them quite immediately with the beta blocker. So it is quite safe for you to initiate beta blockers during the hospitalization.
Even during the initial phase, sometimes I find it quite useful to actually bring down the heart rate even when they are in overt heart failure.
Yeah, that's right. Yeah, but then I will be cautious if it's congested. I think that's the only time that I will be a little bit more careful, initiating beta blockers.
Okay. Dr. Elma asked, if the patient came for follow-up after being discharged from the ward 2 weeks after an acute heart failure episode, underlying hypertension on amlodipine and furosemide 20 BD, the patient's symptoms are improving, but still complaining of exertional dyspnea and fatigue on and off. How do we manage this kind of patients in primary care while waiting for appointment in hospital? Do we increase the furosemide, add on beta blocker? Okay. I think, AZMEE, you can answer. The talk in itself is self-explanatory.
Yeah, I think you should not wait, I think, in terms of initiating GDMT. So as long as the diagnosis is clear. So the only thing is, the question is, if you know whether this is REF or PEF, then you can target your treatment. So if you know that if it's REF, it's heart failure with reduced ejection fraction of less than 40%, then you can initiate safely, the 4 pillars of treatment. Of course, you need to monitor the blood pressure, monitor their heart rate, looking at other things, for that, of course. But then it is safe for you to initiate. I don't think, you need, for them to be seen by cardiologists before initiating, as long as you have the right diagnosis.
It is easy to treat patients who have higher blood pressure with heart failure than a patient that has low blood pressure. So like in this case, right, you have a patient even on amlodipine, the blood pressure is 140. Convert the amlodipine to your ARNI or your ACE inhibitor. And then use a beta blocker on top of that. Okay, because you're not just trying to treat the symptoms, you're trying to treat outcome.
Yeah. The other thing is, of course, out of the 4 pillars, I think, and we mentioned again just now, SGLT2 inhibitor is one of the easiest to initiate, right? So, and of course, if you initiate somebody with heart failure, it is class 1 recommendation across ejection fraction. So regardless whether it's PEF mildly reduced or reduced ejection fraction, you can't go wrong with giving SGLT2 inhibitor.
Especially for a GP, you don't have to worry so much whether you have an echo, but see a patient with, what you think is heart failure, you can start on that. And then when you actually give the patient diuretic, instead of giving slow K, I always give aldactone.
Yeah, of course. Yeah, spironolactone.
Yeah, spironolactone, sorry.
Yeah. So, I think, definitely, I think because it helps with the prognosis of the patient and also helps to improve the potassium.
Yeah, that's right. So okay, Dr. Gunalani said, if persistently having acute pulmonary edema, any other management other than to start spironolactone? Oh, of course.
I think, first of all, diuretics of choice is still furosemide.
Yeah,
in,
that's
in
right.
patients who are congested or in EPO, in pulmonary edema. So diuretics of choice is usually furosemide. And of course, I think if you notice just now, I give bumetanide for my patient is because the patient has some ascites, and sometimes bumetanide is absorbed better if you have a lot of congestion, a lot of ascites, but furosemide is still, spironolactone can be added on as well on top of that, for improvement of the symptoms and also the prognosis as well as one of the pillars of heart failure with reduce. But I would still go for furosemide, for patients with EPO.
Yeah,
Mm.
me too. I mean, it for symptomatic relief.
Yeah.
But furosemide, of course, doesn't change the prognosis at all.
No. But it improves this, yeah.
Yeah, but it's very important to relieve patients of symptoms in acute pulmonary edema.
Yeah.
It's very distressing, I mean. Okay, any more question? Let me see. Any more? Okay, hold on. I need to do something first. Okay, sorry about this. Okay, done. So everybody watching, please, you can register your eCert and your CPD points now. I've made some mistake and I've made some changes. So please.
There's a question I think here from Dr. Key about
Yes.
patients with bradycardia. I think, so I have a patient with heart failure on all pillars of anti-failure, came back multiple times with dizziness, not to have bradycardia. It gets worse despite reducing the dose of beta blockers. What is the next step? I think this group of patients, you require a Holter and ECG monitoring, to see, whether there's any higher degree blocks of your heart block. And of course, if there are, then you have to consider pacemaker, for this patient. I think it is important. And of course, if the bradycardia is very, very symptomatic, you probably need to completely stop the beta blocker. It is quite dangerous for you to continue.
Okay, patients with heart failure with bradycardia, are they have worse prognosis?
Yes, that's right. Reason why it's similar to patients with a low blood pressure as well. They have poorer prognosis, very difficult to treat, and these patients usually doesn't last. And of course, when you have cases like this, then you always consider about device therapy for them.
Yeah, but even then also, I really don't like to see patients with heart failure, with bradycardia and low blood pressure. It makes me uncomfortable. I can't start treatment, and I can't titrate it.
Yeah.
And it's so difficult to explain to patients that the option.
But of course, as I said, you need to know what is the baseline, heart rate, and a Holter will actually achieve that, and don't be shy away, because some of them maybe will require CRT, or even, a dual chamber pacemaker. I think there's a question, here about sensitivity to furosemide. Okay, I don't know about you, Betty, but then I don't see any increased sensitivity to furosemide. The only thing is you may get some patients who are diuretics resistant. Okay, that's quite different, because diuretic resistance is meaning that if they're so congested, if the renal perfusion, renal congestion is so high, that this patient sometimes doesn't actually respond to diuretics. I think that's probably what it is, rather than not sensitive anymore to furosemide. So in this group of patients, a lot of them actually requires a higher dose of diuretics. You need to give them.
That's what I was going to say.
Yeah, you need to give them higher. You have to, of course, intravenous diuretics, give them higher dose, for you to decongest. And the only way is to get them, is to decongest them. So whether you give higher dose, whether you add other diuretics, you combine, for example, furosemide plus tolvaptan, for example, so you can combine other things. You can combine with hydrochlorothiazide, for example. You need to, block the other nephrons, part of the nephrons as well.
Sometimes to treat heart failure, you need to be very brave as a doctor. You have to increase your furosemide dose. Sometimes you need even to give infusion. It's just And then even when you see the creatinine going up a little bit, you still need to persist with your furosemide. You just have to carry on until they feel better.
Yeah.
And
Yeah.
wait for the creatinine to come down when you tail it off.
Yeah.
So difficult. It's not easy to treat. Most patients are easy to treat, but not all patients are easy to treat. And you have to individualize your treatment.
Yeah. So,
Every time you send it to AZMEE.
of course, I didn't go through, the treatment of acute heart failure here, using diuretics resistance and inotropes. Perhaps there's something that we can consider, looking into it, because I think this lecture today is just looking at the broader picture,
Yes.
of the treatment. But of course, there is specific part of the treating acute heart failure is also quite interesting for us to discuss.
We just want the GPs and the junior doctors to know the recent drugs we can add on to our heart failure treatment. Okay, and then the safety of the treatment when it's an outpatient clinic and you think that you can't get an appointment to see cardiologist, you can start treating. What can you use? Okay, and then of course we want you to know that there are options other than just pharmacological treatment.
That's right. Yeah.
I think it was a great talk.
Thank you very much.
When I say that, it means that I'm going to invite you for more talks.
Thank you very much, Dr. Betty. Always a pleasure, even if it's 10 o'clock at night, no worries.
Yes. Okay, so I'll see you on Tuesday.
Okay, will do.
Yes, bye everyone. Join us again next week.
Bye-bye, everyone.